I'm going to be performing a cardiac assessment on my patient. I've already completed my national patient safety goals. So the first thing I'm going to do is note any obvious signs of cardiovascular issues. This can be shortness of breath, chest pain. I would also want to look for edema in the upper extremities and the lower extremities. And I would also want to note any cyanosis, so that can be present around the mouth or in the hands and feet as well. So I'm going to be looking for those things. If I note that my patient has any of those obvious signs of cardiovascular issues, I would address those issues, and if they were life-threatening, I would stop my assessment and go get help. My patient does not have any obvious signs of cardiovascular issues, so I'm going to proceed with my assessment. So next, I'm going to inspect and palpate the neck for carotid pulses. My patient's carotid pulses are along the sides of his neck. I am going to palpate one side at a time. The reason I don't want to palpate both at the same time is because it can make my patient pass out, and I do not want to do that. Next, I'm going to assess for jugular vein distension. This would be noted also on the sides of my patient's neck. Jugular vein distension is abnormal, and it is a sign of congestive heart failure. So I do not want to see that on my patient, and my patient does not have JVD. The next thing I'm going to do is auscultate. I'm going to auscultate the neck for bruits, and I'm going to auscultate for bruits with the bell of my stethoscope. A bruit is an abnormal, turbulent sound coming from the artery, and it's a sign of blockage. So when I listen to the neck, I should not hear anything. If I hear a turbulent blowing sound, that would be a bruit, and that would be abnormal. So I'll listen on both sides with the bell of my stethoscope. I do not hear anything, and I do not hear any bruits, so that is great. The next thing I'm going to do is lower my patient's gown, and I'm going to inspect and palpate the precordium. I should not see any visible pulsations on my patient's chest. The next thing I want to do is palpate the point of maximal impulse. You can use the 2 fingers, or you can use your hand. So I can palpate my patient's point of maximal impulse. If I had a patient with large breasts, I could ask my patient to lift her breast, or I can use the back of my hand to lift the breast and feel for the point of maximal impulse. Okay, and then the next thing I'm going to do is listen to the 5 auscultatory sites, and so I'm going to use the diaphragm of my stethoscope to listen to normal heart sounds. The first heart sound is the aortic heart sound, which is going to be the second intercostal space on the right sternal border. So we have our clavicles here, and right below that starts our ribs, and intercostal spaces are the spaces in between the ribs. So like I said, the aortic heart sound is going to be here at the right sternal border, second intercostal space. The next spot is going to be the pulmonic heart sound, which is the second intercostal space, left sternal border. Right below that is Erb's point, which is the third intercostal space, left sternal border. Next is going to be the tricuspid, which is the 4th to 5th intercostal space at the left sternal border. And the final spot to listen is going to be the mitral or apical heart sound, which is the 5th intercostal space mid-clavicular line. So it's going to be in the middle of the clavicle. And so I never want to see your stethoscope past the mid-clavicular line when you're listening for the apical pulse. So just to recap, these are the spots where I'm going to listen to the heart: aortic, pulmonic, verbs, tricuspid, mitral. And I'm going to listen to the apical pulse for 1 full minute. This completes my cardiac assessment. Before I leave the room, I'll make sure that my patient is safe and the bed is in the lowest position.